I will be muting all. So those who want to speak, please unmute and talk. Is it okay? I'm muting all. Okay.
I think we can start, so it's 9:05.
Yes.
Yeah. We can start now.
Yes, ma'am. Good evening, everyone. I am Dr. Kushal, Secretary of IAP Karnataka. I welcome you all for Samanvay K. I welcome the seniors, Dr. Pramod sir, Dr. Srinivasan sir, and I welcome our Dr. Jose sir, our Vice President South Zone, our Central EB members, our President Bangalore, Dr. Raghunath, and Dr. Ganesh Kulkarni, Dr. Basuraj sir, Dr. Kashi sir, Atanu Batra sir who has joined, and our speakers and moderator Dr. Kashi sir, Arun Wadhwa sir, Vijay Alve sir, Jaideep Chaudhary sir, and our coordinator Dr. Nandi sir, and our convener Dr. Sumita Nayak. And I would like to ask Dr. Ravi Shankar, our president, to give opening comments.
Yeah, thank you, Kushal. I'm happy to invite all of you to our K Samanvay, where we'll discuss the things, then we can understand whatever the new latest things are there. So in this session, we requested Dr. Kashi sir to give a deliberation on immunization. So many new things have come there, so easily accepted, and I really thank you, sir, for that nice gesture you showed on us. And also same time, I welcome Dr. Vijay Avale. My almost he's like a godfather to me in my ID thing. So I welcome you, sir. And also Vijay Avale, my another best friend from West Bengal. And Wadhwa sir, everybody I welcome. And I'll also welcome my teacher, Dr. Srinivasan here, who is there here. He will be there in everything. That's what the joke we had, Ganesh Kulkarni was telling. So the number of webinars he has attended is more than anybody else has attended, and we can give an award to him like that one. So really his enthusiasm is so great. We should be like that, like him only. Even every time he wants to learn. I welcome you, Srinivasan sir. So hand over to Kushal back.
Thank you very much, sir, Dr. Ravi Shankar sir. Now I'd like to ask our South Zone Vice President, Dr. Jose, to give a comment, sir.
Thank you, Kushal, and respected President of Kannada, Dr. Ravi Shankar ji, the convener of the program, Dr. Sumita Nayak, the coordinator, Dr. Nandish, our past president, Dr. Basaraji, and today the leading faculty, Jaideep Chaudhary, Vijay Avale sir, Kashi sir, and Arun Wadhwa sir, and all the dignitaries on the dais, and good evening to all. I think IAP Karnataka State under leadership of Dr. Ravi Shankar ji and Dr. Sumita and other leaders of the Karnataka are doing a wonderful job. Very useful topic for day-to-day practice. They started from last 3 topics. One is allergy topics, first very useful. Second, yesterday was last topic was a joint pain approach. That's also very much appreciated by lot of members are attended through Zoom meeting. I think today the vaccinology, the bread and butter of pediatricians concerned, going to enlighten with a esteemed faculty. Will be very much fortunate to have this much faculty from the vaccinology to have discussion on the common issues in vaccinology. I wish you all the best program. Jai Hind, Jai AP.
Thank you very much, sir. Now I'd like to ask our coordinator, Dr. Nandish, to give a comment.
Kushal,
Thank you,
Basraj sir.
Dr. Kushal. Yeah, let Basuraj sir give opening.
Basraj sir, ಕೇಳಿ sir.
Yeah,
Kushal?
thank you very much,
Yeah.
Dr. Kushal, Ravi Shankar, Sumita, Dr. Nandish for coming out with the excellent program. Best wishes. Thank you.
Nandish.
Thank you,
Yeah.
sir. Dr. Nandish.
Very good evening to all the esteemed dignitaries present here. Today we are learning from the legends, Dr. Kashi sir, Dr. Vijay Avale sir, Dr. Jaideep Chaudhary sir, and Dr. Arun Wadhwa sir. We are indeed very honored to have the esteemed speakers who are here to enrich with their knowledge, deep insight in the subject, current practices or current issues in vaccinology. We thank all the delegates who attended today and making it successful series of programs K7 with all your presence. It's becoming successful. Very thank you. All the best wishes for the program. Thank you all for joining. Over to you.
Thank you very much, sir, Dr. Nandesh. Thank you very much, sir. Now I would like to hand over to coordinate Dr. Sumita Naik, our convener, to coordinate the program.
Thank you so much, Dr. Kushan. Good evening and warm welcome to all our esteemed guests, seniors and teachers who have joined in the session today. It's indeed an honor for me to be introducing our moderator for this evening, none other than Dr. Srinivas Kasi sir. Dr. Kasi sir needs absolutely no introduction. He is a mentor and guide to me, and he is known to all of us in the field of vaccinology and to all the IAPians across the country and overseas. Thank you so much, sir, for accepting to do this session. Sir has been the convener of the ACVIP for 2 successive terms. Subsequently, he was the advisor for the ACVIP. And I think there is no question which Kasi sir cannot be answering and clearing the doubts which are lingering in our minds. As was discussed, today's session will be talking about whatever controversies, whatever confusions are there regarding the newer vaccines and the newer developments, especially in the field of vaccinology. So with this, I request Kasi sir to give a few opening remarks before we start.
कैसी है chocolate आपकी?
Oh, that's
Shruti
nice.
is
Someone is
there,
offering
Shruti is the
chocolates.
anchor.
Ravi
Sumita,
Shankar
Shruti is the
sir,
anchor.
sir will give a few opening remarks and then we'll hand it to Shruti to introduce the speakers. Sir, a few opening remarks from your side, sir.
Okay.
Kasi sir.
Okay. Thank you, Dr. Sumita. I think it's I think someone is talking on my behalf.
ಸ್ವಲ್ಪ mute ಮಾಡ್ಬಿಡಿ. Thank you.
Sir, Kashi
Okay.
sir.
Yes.
Once again, I will mute all and you unmute yourself. Okay. I think
Okay,
somebody,
done.
yeah. Yeah.
Okay,
Now you
thank you.
unmute, sir. Yeah.
Thank you, Dr. Sumita, Dr. Ravi Shankar, and all the people responsible for this particular program. The last few months have seen many exciting developments in the field of vaccines, both new vaccines and changes in schedules, and many other issues, boosters, etc. So I think today's session, I've planned it in such a way that many of these issues are going to be discussed today. And well, I'll just wait for us to start before any other formalities are to be completed. Thank you.
Thank you, sir. I now call upon Shruti. Please introduce our panelists and then we can start the session.
Good evening, everyone. It's my pleasure to introduce our panelists for today. I would like to introduce Dr. Arun Vadva, who's a consultant pediatrician at Rainbow Children's Hospital. He's the editor of various books on vaccines. He has 22 book chapters, 12 national and 3 international journal publications to his credit. And he's the national trainer for various IAP vaccinology courses. Thank you for joining us today, sir. I would like to next introduce our panelist. Our next panelist is Dr. Jaideep Chaudhary. He's a professor in the Department of Pediatrics from Institute of Child Health, Kolkata. He was the Vice President, East Zone Central IAP in 2019. And he's been the editor and author on various books and journals on pediatric infectious disease. Thank you, Dr. Jaideep Chaudhary, for joining us today. And we have our third panelist for today, Dr. Vijay, who is the head of Apollo Children's, Navi Mumbai, and Dr. Wale, a multi-speciality hospital. And he has over 50 publications in peer-reviewed journals. So it's our pleasure that you have joined us today. Thank you so much for joining us in today's session. Ma'am, we can start off?
Yes, please. Kasi sir over to Kasi sir. Sir?
Okay, thank you. I'll just share my slides. Right. So thanks once again Dr. Ravi Shankar, Dr. Sumita, and the entire team for making this particular session possible. We are going to discuss certain issues which are of current interest. And as a moderator, I have a formidable array of panelists, and I don't think any moderator can ask for anything more than this as far as the quality. Arun, who is extremely well read, same with Jaideep, and of course Dr. Vijay, who is a sort of a patron and someone whom I looked up to a lot during my initial days of interest in vaccinology. So let's get going. One of the most, I won't say controversial, but confusing aspects is the HPV vaccine dosing, right? In 2022, the WHO published a position paper. Just look at the words. Current evidence supports the recommendation that a 2-dose schedule should be used for this particular age group. They go on to say alternate single dose schedule as an off-label option for girls and boys between 9 and 20 years of age. They also go on to add that from a public health perspective, the use of a single dose schedule can offer substantial benefits that outweigh the potential risk of a lower level of protection if efficacy wanes over time, although there is no current evidence. I think it really this is a masterpiece of a statement because it reveals everything at the same time. It doesn't give you any answers. Okay, it doesn't give you any clear guidelines. And over and above that came the recent campaign for introduction of HPV in a campaign mode for girls who are between 14 to 15 years with the Gardasil 4 vaccine. So now, where are we? Is one enough or is two better? This is what we got to discuss today. And I think, as I said earlier, I'm sure the panelists are going to do a great job of it. Now, if you remember, when the HPV vaccines were first licensed, it began with 3 doses for 9 to 45 years. Subsequently, it was reduced to 2 doses for those between 9 and 14 years. And now there is a suggestion that only a single dose for 9 to 20 years. Now, Dr. Arun, can you tell us why it began with 3 doses and why did it change to 2 doses for those between 9 and 14 years? So that we'll have some background for the 1 dose. I would like you to specifically restrict to these 2 questions itself. Dr. Arun, please.
So good evening. Thank you, everyone. When this vaccine was kind of made 18, 19 years ago, we were looking at the antibody levels. And when people used to miss the doses because they were checking the levels, they said that, people who take 2 doses, 1 dose, the levels are quite low and may not work. It's only later on they found that 9 to 14 years, even 2 doses were giving good levels, good immunogenicity, as much as the 3 doses which were giving after 15 years of age. And now gradually we have come to know that it's not the antibody levels which actually matter. It is the antibody level at the tissue level, which can be even just by picograms, which will help in protection. So it's not the high antibodies in the blood which help. It's the the picogram levels, which is at the tissue, which helps. So, and they found that even 1 dose gives you that much of level, although long term, we don't know, like the statement said, but these small minuscule amount of level in the tissue also is protective.
Right. So please remember there is no correlate of protection for HPV vaccines. But we know that the vaccines induce very high antibody titers. But incidentally, in the future 2 studies regarding Gardasil 4, HPV 18, almost about 40% became seronegative at 18 months. But still, there was undiminished efficacy till almost 14 years of follow-up, indicating that absence of antibodies in the blood, which are detected by the currently available methodologies, does not mean no protection. Because, as Dr. Arun said, the amount of antibodies we need for protection at the cervicovaginal mucus secretions is in very, very, very small quantities. And that amount can be present in anyone who has seroconverted, even if the lady becomes seronegative over a period of time. So now we come to the next question. Why is this not moving? 1 second. Okay. Now, Dr. Jaideep, the concept of one dose began quite some time back, and they were based on just 2 studies. Can you give us some idea about how this concept of one dose began, how that one dose may work?
Thank you so much for hosting this discussion. Well, as you have already shown that it was 2022 that WHO came up with the idea, but it all started quite a few years back. It was around 2004, 2005 when the CVT, that Costa Rica HPV vaccine trial was done, and it was about 7,500 women, and it showed protection of more than 80%. Then there was another study which was an India-based study. It was the IARC study. It's the International Agency for Research on Cancer, where the cohort was a larger one. It was 17,000 women, and the efficacy was more than 92% with single dose, and as we have already been discussing over past few minutes, it persisted. So both these studies showed the efficacy of a single dose, and that too on a follow-up, and that really prompted WHO to think in term of reducing the doses.
Thank you, Jaideep. I think very clearly mentioned. We must remember that although both these studies gave us some robust data, a good data, still they were not sufficient to make decisions regarding one dose, because the Costa Rican vaccine trial, it was a post hoc analysis. It was not in the primary endpoints of the study. The IARC, which began as a randomized control trial, we are all aware due to non-medical reasons, it was halted and it became an observational cohort study. And a post hoc analysis and a observational cohort study are not the highest level of evidence. And when you're making such great decision, you require evidence of very high quality. So, Dr. Vijay, what further data was generated to support the recommendation? And at present, how robust is the data for recommending a one dose schedule now?
So
Dr.
first of
Vijay,
all,
please.
thank you very, yeah. Can you hear me? Thank you very much.
Yeah, very well. Yes.
again.
Yes, sir, yes,
Yeah.
sir, we can hear
So-
you. Yeah.
So thanks a lot for this opportunity. And first of all, the study was done with 3 doses to begin with, because like any other inactivated vaccine, this is a VLP vaccine. So it works on prime boost principle, and on that basis,
Yes.
earlier studies were done on 3 doses. Then there were indications uh, for a variety of reasons, missed opportunities or dropout, that Dr. Kasi mentioned about future trial, where we do not have definite serologic correlate of protection in terms of antibody titers, but the efficacy persisted despite almost vanished titers. Similarly, post-hoc analysis, as has been alluded to, both the Costa Rica and the Patricia trial also gave an indication that less than 3 doses would also suffice. Then WHO changed to 2 doses. But as Dr. Kasi said, this is not a very robust evidence primarily. So the first evidence came from a RCT which was done in Kenya. So they compared the single dose of the bivalent and the nonavalent vaccine. And at the end of 3 years, it exhibited an excellent efficacy, 97% plus. Then came the Escudo trial, which is a true study which looked at the non-inferiority of uh, 1 dose versus 2 doses. And it also spanned over a period of time, almost 10, 11 years, 7 years. And that also established the fact that a single dose is as good as 2 or 3 doses. Though the antibody titers with less number of doses are inferior, as we have discussed earlier, it really doesn't matter. And then the Kenshi studies correlates where the antibody titers were compared with the CVT subjects also. So all in all, after the initial indications, the researchers started looking at a robust evidence, and today we have ample evidence to say that though the antibody titers with lesser number of doses are lower, uh, it no way there is no linear correlation with the antibody titers and efficacy. Efficacy persists even with a single dose over a period of time, as long as 15 years. The IARC, for example, the observational study does indicate persistence of efficacy for almost 15 years.
So I think many RCTs were done to, sort of prove what was suggested in those two post hoc analysis. I mean, Dr. Vijay mentioned Kenshe, then we have the Doris trial, then the Escudo, the
Escudo.
Primavera, then the study done in Thailand, the HOPE study done in South Africa, whose results has already been published. And now we have data till about 5 years of follow-up showing sustained efficacy against persistent infection for 16 and 18, even against the 5 additional serotypes, because in many of these studies,
Absolutely.
the 9-valent vaccine also was used. Now, Dr. Vijay, again, how robust is this data to take a decision? The presently available data, how robust is it?
Well,
You feel it's class
well,
1 A grade?
so in terms of the RC, it is a class one evidence, but
Yes,
the duration is maybe 5 years, seven
short.
years. SQ is looking at 7 years. However, the
Yes,
observational studies and the post hoc analysis are indicative of a very long-term persistence of efficacy. So if you put 2 plus 2 together and look at the public health burden that HPV cancer, the cervical
yes,
cancer is, uh, it is I think it is time to in the larger interest of the community it's a right decision taken by the government of India to introduce one single dose for young adolescent girls. That
so
should work, and obviously these cohorts are still under observation and they are being followed up. Escudo
right,
especially, they are looking at 7 years and longer
yes,
data. Yeah.
right. I think whatever data we have so far is really an extremely high quality data showing that one dose may work. So probably the ball is moving into the court of a one dose schedule. Now, again, Dr. Vijay, are there any consideration against a one dose? Is there something in your mind which tell you maybe I should go a little slower? Remember, I'm not talking about public health. I'm talking about IAP members, what they should do.
Yes, certainly for IIP members, when it comes to individual protection, one
Yes,
will have to offer the best possible.
yes,
Because when we vaccinate young girls and the disease occurs at a very higher age. So we are looking at, protection over a period of time,
yes,
decades. So whatever observational data is there is for about 1.5 decades or so. So
right,
maybe for an individual protection, it's a little premature. Secondly, those with immunocompromising conditions, I would
right.
definitely not suggest a lesser number of doses. One should definitely complete the full schedule. Finally, the endpoints which all these RCTs or observational studies they have
Yes,
looked at is CIN2 and not
yes,
this. I mean, to wait until cervical cancer will be unethical. So these are a few limitations. So we need to have take into consideration all these, and in individual practice one would not cut corners and offer the bare minimum 2 doses at the age that IAP has recommended, unless we have a very long term follow, maybe 5-10 years from now, uh, as the studies mature and we have more data of longevity, maybe one could change over to a uniform schedule for both the public health and private sector.
okay. Now, Dr. Jaideep, how many countries adopted a one dose schedule in their NIP? Can you give us some
Well,
figures?
yeah, well, that we all know that India has adopted it very recently, but it was in Nigeria, it was introduced around 2023. Approximately, there are 90 countries all over the world, some Gavi eligible countries also, Bangladesh, Indonesia, some Southeastern Asian countries. So overall, all over the world, approximately 90 countries, they have a single dose in their national immunization program.
Okay. So I think these points have been put forth very well about the robustness of the data, and there is some shortcomings, especially the lower antibody titers with one dose. But we must remember that after the first year, between 1 year and almost 16 years, the antibodies have plateaued. They have not fallen. So that gives us a lot hope that even with one dose, with one dose, the antibody titers are going to persist. So we are also concerned about long-term protection. Whatever data has been generated is only against persistent infection, that is cervical cancer, and only in females. Will this also hold true to males? Will also hold true to other HPV related cancers? These are some of the unanswered questions. Sorry. So, with all this data in hand, a question to all: should IAP recommend a one dose schedule today? Just yes or no. Arun, let's begin with Arun. No ifs
Like
and buts. Yes or no?
like Dr. Vijay said, it's too early to really go into it because we are looking at individual protection.
So you are
So maybe
saying
later
no.
on. Not yet.
No. Jaideep.
No, not yet. We don't want a knee-jerk reaction. I mean, ACVIP has stood with, say, the IPV schedule, the pneumococcal PCV schedule. So we
Yes.
can wait, I mean, till the time comes.
And Vijay, if you were the convener of ACVIP and the president is quite keen on a one dose schedule, what will you do?
At this point in time, I would not be very keen on changing the schedule. I would
Right.
offer. I would not offer
Yeah.
single dose.
I think the points are very well discussed.
But
And I
but
think
at
that,
the same time, there's always a problem in dichotomy between the public health NIP
yes,
and
yes.
or campaign
Yeah,
mode and the IAP recommendation.
exactly.
But we must try to put it in a proper context to the patients who come to our clinic. That's very important.
Exactly. I
Yeah.
think
One more thing might happen, because all these studies are more for girls and women. So, if even if IAP just goes on data only, they'll probably make it one dose for girls and two dose for boys. That also will be difficult. So
I
it
know
has
it
to be
won't make
each.
sense. Yeah.
It should be
Arun,
uniform. It
one
should be
more thing.
uniform.
Arun, one more thing. It is the HPV4 Gardasil which is put to use in.
Yes.
We are yet to generate data about the serum vaccine,
Right.
which is likely to be used in public. Of course, they also have submitted some data, but
Yeah.
maybe for a single dose, it's too early to make a recommendation.
Yeah. See, the WHO has said that for vaccines which are licensed on basis of non-inferiority to another vaccine which has efficacy data, non-inferiority of the immune response should be persistent and proven till at least 2 years of follow-up. And I think there are certain Chinese vaccines which have been licensed recently for one dose. The serum vaccine, the studies are on. 1 year data has been very encouraging. And I think once the 2 year data comes, I think it may get a
Yeah.
pre-qualification for one dose. So that is as things stand. General consensus, at least of this panel, is that I'm marking my words. It is this panel is that maybe it's a little too early for one dose now, and we should have a little more robust data because as far as recommendations for IAP members is concerned, we are looking at what is the best for an individual child and not what is just acceptable. Right. So let's go to the next. Well, do we have a new savior on the horizon? I'm talking about dengue vaccines. Is it a fact or is it shrouded with a little mystery or myth or inconsistencies? Okay, Dr. Jaideep, first, to implement any vaccine, we have to know the burden of the disease. So I wanted to discuss what data is there about the seroprevalence and the serotype distribution of dengue in India. Are there any published studies, any recent data? Can you just elaborate on this?
We have limited data on exactly the seroprevalence and serotype distribution as of India.
Yes.
But what we know that there is always the changing epidemiology, and the DEN 1, 2, 3, 4, there is co-circulation of all the four serotypes, and there is some cyclical distribution, dominance also of one serotype over.
Cold medicine ಬರ್ದಿಲ್ಲ, cough medicine ಬರ್ದಿಲ್ಲ.
Oh, wow. Who's that? Yeah. Please go ahead. Please go ahead.
Yeah, well, maybe about 10, 15 years back, it was the DEN 1 and DEN 3, which were the dominating serotypes. Then DEN 4 came up, and then since then it has been dominant. But again, DEN 4 is more often seen in southern state and hardly in the eastern part of the country. So there is limited data. Well, there is a huge diverse epidemiology in India about the serotypes and also the seroprevalence. So we have to be on guard. That's the main thing. We cannot just say that a particular serotype is predominant in India at present, and maybe this as the season change, maybe in the next dengue season, it will be totally different.
So I think there's one population level seroprevalence study which was published in 2023. And what that showed was that overall prevalence was about 53%. And we
Yes.
definitely had a significant burden of dengue 3 and 4 also, specifically in the southern and the western parts of our country. So we have dengue 3 and 4. And this has relevance because we are going to discuss about the vaccine very soon. Now,
But in
Arun,
this, I think, the prevalence was around, say, 56. Mostly it was in South, which was around 70, followed by West, followed by North, and
yes,
least the
yes,
Northeast, which was only 5-7%. So it's
yes,
starting from 70% in South to 5% in Northeast. And
yes,
mostly they were 1 and 3. In Delhi, it's mostly 2, what we get, and 4 is now
yes.
coming up South. So I think it's going like clockwise. So
Yeah,
4
I
is
think
coming, so soon we should have
last
it.
2 years, at least in Karnataka, we had dengue 3 and dengue 4 outbreaks. Okay.
But if I may come
Now,
in here,
yeah,
Dr. Kasi, nationally represented data is very robust data is not clear. There is
yeah, please
always
go on.
underreporting. For every
Yes,
reported case, it is estimated there are 300 cases which are not reported. Number
300
one.
Yeah.
cases,
Number
not
two, all said and done, it is since 2012, it is the dengue 2 which has been the major player.
right.
Uh, dengue 3 and 4, as you put it very correctly, is trying to establish in the southern part of the country. There was a feeling that post COVID, there was a bit of lull, but that was also not seen uniformly. Dengue continues to be a major public health problem. And there is no doubt that we need to prevent dengue. But as you said, the epidemiology, and as Jaideep said it is evolving, it is changing. Unfortunately, we do not have a very robust data. There are estimates, but there are indications that DEN 3, 4 is surfacing in southern part of our country. Rest of
When
the
it is
country is still saying dengue 2.
300 times less reported, it's very difficult to say.
Yeah.
Yeah. See, we must remember that this seroepidemiology is something that is time specific. If you look at that published data about dengue, the same dengue vaccine in Brazil, where they used as an outbreak, in the beginning of the outbreak, dengue 1 formed 80%, and dengue 4 was less than 2%. And by the time the outbreak ended, which lasted for about 7 months, dengue 3 was almost 40%. So things are going to change. So just absence at one particular time point does not mean that the other serotypes are
Absolutely.
there or not there. So I think we need to have an open mind about it. Now, when we want to
True.
give a vaccine, we need to know at what age group the disease occurs. So what age do we start? So what is the age distribution of dengue in our country? Which is the peak incidence? When do we really start seeing dengue cases as a public health problem? Dr. Arun, some thoughts about
So,
this?
yeah, actually, we would see dengue cases all across the age groups. So, but in
Yes.
that serotype distribution prevalence study, which you were quoting last
Yeah.
question, there they found almost like 24% in children 5 to 8 years, and then
Yes.
40% 9 years to 17 years, and rest around 50% plus that. But we can't say because 3 years, it's only 3 years, 5 to 8%, 5 to 8 years is 24%, but 9 to 17 years, which is long range, it is 46%. So most of these children, that means more than 50% happen below the 18 years of age, which is our age group.
And incidentally, that study did not look at dengue below 5 years at all.
Yes. Yeah, he did not
They
study
did
less than
not
Yes.
5,
look at
but we
dengue
do
below.
get less than 5 years too.
Yes, we
Yes.
do. So age distribution is right from a young age. Is it 3 years, 4 years, 5 years? We don't have any robust data, but it's almost in keeping with what is found internationally. Now, in the TIDE study, the pivotal study for the QDengue or the TAC 003, there was no demonstrable protection against dengue 4. There were no dengue 4 in the study areas. The protection against dengue 3, both against virologically confirmed and dengue hospitalization, was very poor in the seronegatives. I mean, almost came to negative values within 18 months of giving the vaccines. How crucial are these findings in recommending the dengue vaccine in our country, Dr. Vijay? Should this
So
be
first of all,
deciding factors or something that may
so let's
not
try and
be
understand.
crucial?
Yeah. So let's try and understand. One thing is certain that we need to have a vaccine which would offer a sort of a balanced tetravalent response so that we don't burn our fingers again like what we did with the previous vaccine. We, in the
Right.
sense where it was used, it led to ADE, antibody dependent enhanced primary
Yes.
disease in seronegative population. So this is an
Yes.
important aspect to look into. However, if you look at the TIDES data, it was concluded the data published was at the age of at 4.5 years after the second dose. In that
Yes.
study, there was no protection against seronegative DEN3, and the confidence intervals were very wide, crossing zero. And
Yes.
there was a problem with Sri Lanka also, because Sri Lanka, each and every patient gets admitted.
Right.
Unfortunately, whatever DEN3 occurred in the vaccine arm, and it gave rise to an exaggerated
Right.
negative, efficacy against DEN3. But if you remove that data, then also there was no substantial, efficacy against DEN3 in seronegatives. But an unpublished data or the poster which was presented at WISPID, which looked at 7-year follow-up of the same cohort,
Right.
the confidence interval started narrowing a little bit, but still there is an overlap, and we cannot confidently say that it would offer protection against DEN3. However, one good thing is there has been no ADE, though the efficacy has not been established against seronegative DEN3. There has been no ADE until 7 years. And secondly, you just now spoke about Brazil in 24 when they used this vaccine. Of course, they used in higher age group in
Right.
adolescents between 10 and 14
Yes.
years. And the epidemiology changed from DEN1, DEN2 to DEN3, about 38% in the last part of the. So with not a very great coverage, they could have very good effectiveness, real world effectiveness using this vaccine. The force of infection was so intense that the efficacy which was established in the control trial condition was the effectiveness not as high as the efficacy, 84% against hospitalization, but it was around 60, 67% in
Yeah.
the real world. However, there was no AD again in that. So that is really reassuring that we may not have very robust efficacy against DEN3, but it looks like that it may not lead to AD in seronegatives. So
Right.
that is one plus point. But we need to be vigilant, especially on the background that seronegative DEN3, I mean DEN3 and DEN4 has started surfacing in southern part of it. I looked at a report from Bangalore itself in
Yes.
2025. They had
Yes.
substantial DEN4. But of course, that
Yes.
cannot be extrapolated. But as we all understand, the epidemic seroprevalence keeps changing. So there is a substance in this doubtful efficacy against DEN3 and DEN4. However, the positive side is there is no additional safety signal. And in the absence of a best vaccine, this is something which can definitely put to use, and we can save lives or
And I,
hospitalization at least. The burden
in the
can be lessened.
TIDE study, I think there was also a disease modifying effect of the vaccine,
Absolutely,
where it
yes,
reduced the severity of the disease in the vaccinated, and that itself
definitely.
should be a good plus point. Of course, this is not a vaccine where we can blindly welcome it with open arms, but at the same time, we definitely cannot reject it because of the disease burden and the benefit to a significant person. I mean, if our overall seroprevalence is 55 to 60%, it's definitely going to benefit the majority of the vaccinees.
Definitely. And
Now,
in the absence of something which is best, let's not lose out on something that is good. No.
right. Now, is there any more data that has come? I don't think there's any post-marketing data now which has suggested that there is some efficacy, because I think the only study is the Brazil study. There is no data that has
And
come
these
out still.
and the 7-year follow-up, they boosted
Yes,
a few of the subjects, but
right.
there is no significant improvement with the booster. However, the confidence interval for efficacy and entry, it got compressed a little bit, but still overlap. Difficult to say that it would work against seronegative DEN3 based
Any
on that data.
considerations for boosters?
I said that they looked at booster and the efficacy did not jump significantly, but there was no
So,
waning.
so should IAP recommend dengue vaccine for all with this good data and the known limitations? What do you feel?
Let's
It
see
should
what
not. I
DCGI
mean,
says.
so
Please.
they have received the go ahead from the subcommittee,
Yes,
expert
the
committee,
Page.
yes.
the expert committee of
Page.
NTAGI, and they are waiting for
Sage.
licensure. And
Okay.
it should be put to use. IAP should recommend with caveats, all the caveats that
Yeah.
given the burden and the epidemiology, there is no
What
harm
age
in.
do you think it should start? 4 years, 6 years?
Well, I
I
would, if it is better, I would start at 4 years.
I think
Why?
Why
What
deny that
difference?
opportunity?
no, I think the DCJ has given permission from 4 years of age. So I
4
think
Yeah.
years.
from 4 years,
The expert committee has said 4 years. The
4 years.
CEDESCO
DCJ is,
may
yes, may
usually they
change it.
don't they don't change whatever
Well,
subject
that's
expert
right, that's
committee
right.
recommends. Yeah.
So I think dengue vaccine, when it is available in the market, will definitely be a very welcome addition to our armamentarium to give more reliable positive health to all our children under our care. And incidentally, what about, is there any other new vaccine which is just running neck to neck with this particular vaccine?
So
Briefly,
the TB003 Butantan
yes,
dengue
Butant,
vaccine,
yes,
as
yes,
they have published their 5-year data also now.
yes,
I looked at the data very closely. The
yes.
efficacy against DEN3, DEN4 is not
No,
demonstrated in that
the
trial.
same
One.
limitation, the same
And
limitations. Yes,
what is more important is the efficacy in Deng2 is definitely inferior to that of
yes.
the Q
But
Denga.
that was
Q
tested
And
Denga.
with one dose.
especially in seronegative.
So negatives.
Especially
Okay.
One dose. That's a one dose
with a
vaccine.
very
So
wide confidence interval
Wonderful.
crossing 0.
So, to conclude for the audience, we have a dengue vaccine which will probably be available in the next few months, maybe certainly by this year end. It will probably be licensed from the age of 4 years. The upper age limit will probably be 16 years. But of course, many countries have licensed it even till 60 years also, countries with very high burden disease. It will be a definite benefit in the seropositives, where it has the highest efficacy against DEN2, intermediate against DEN1. DEN3 is little lower, DEN4 we don't know because it was not there at all. In the seronegatives, the efficacy is lower than in the seropositive, but still if you take hospitalized dengue, it is still about 80% even in the seronegatives. So it definitely has benefit in seronegatives. So far, there is no reports of antibody dependent enhancement. So it is going to be a safe vaccine. And as the panelists have said, probably this is one vaccine which we may welcome with open arms, probably unconditionally. Thank you. So the next,
Come and ask.
yes, the next kid on the block is the monoclonal antibodies, the RSV. The question is, it is so expensive. Is it something we should give to all? Should we give it only to select groups? This is what I would like the panel to discuss. So Vijay, what is the burden of RSV in our country? And does it in any way differ from the published Western data? Or is it very similar? Can you give some idea about it?
Sir, may I just interrupt? There is a question relevant to the dengue that whether we should do the serology before giving the vaccine.
No,
In the chat box.
no.
At this
I
point,
don't think. Yeah,
it's not.
please.
No.
Anyone?
Sorry to interrupt because it was relevant, so I just pointed.
Yeah, no problem. Any comments?
No, please proceed.
Vijay, you're
Dr.
muted.
Yele.
Vijay, unmute, please.
Yeah, can you hear me now? Yeah. So all
Yes,
of us, so like unfortunately, like any other disease, we do not have a very robust data. But all of us know that there is a lot of RSV. I came across a meta-analysis which was published in 2025, which talks about almost 12 to 13 million infections a year and estimates of about 1 million hospitalization and about 37,000 deaths. This is a meta-analysis which was published last year in 25.
Right.
And but 20% of the global burden is contributed by India. The difference in the Western world and our world is primarily the access to healthcare inequity, inequality, and so we have a lot of hospitalization, lot of morbidity and mortality which is not reported. Very often the diagnosis is not established. We do not really know the pneumonia deaths which take place, whether how many of them are RSV deaths. Because
Right.
RSV is known to cause bronchiolitis, lower respiratory tract infection, and at other end you have simple URI-like illness also. But there is a definite substantial burden. Lot of hospitalization occurs, especially when we are into a good coverage with Hib and pneumococcal vaccine. It is viruses which are now playing havoc as far as LRT and pneumonia are concerned. So it's
Can
a
you tell us
substantial
something
burden.
about the? Can you tell us something about the PERT study, which so graphically, stress the importance of RSV?
Absolutely. I mean, I may not be able to recall the exact statistical data, but
Yes.
the substantial contribution is by viruses, and of the different respiratory viruses, RSV leads your human metapneumovirus and parainfluenza virus. But RSV is the one of the leading causes of viral respiratory tract infection, LRTI, and
Yeah.
SARI and LRTI both.
So PERT study was on 6 countries, low middle income, Africa and Asia, which was done in 2000, published in 2019, about 10 years after a previous study, which showed that pneumococcus and Hib formed over 2/3 of all hospitalized pneumonia. And what the PERT study was, it looked at the etiology of hospitalized pneumonias in those under 5. 61% were due to viruses, and of that 31% was due to RSV. So RSV has now almost replaced. Streptococcus pneumonia was just around 12%. So with
Absolutely.
extensive pneumococcal and Hib vaccination, pneumonias, LRTI due to those bugs have reduced, and now RSV has risen. So RSV is the next candidate for prevention. Now, what is the incidence in preterms versus high risk, general population, any difference in the age distribution? A little more details about the epidemiology of RSV in our country, Dr. Jaideep, please, because this has a bearing on vaccination and use of monoclonal antibodies.
Well, what we have found that definitely the preterms and low birth weight are at increased risk. But
Yes.
there is a study like one by Vamsi et al., where we have seen that babies born beyond 37 weeks, that is term babies, even 30% had RSV. And even weighing more than 2 kgs, they are also approximately 30% were affected in subsequently by RSV. Though what
Hello?
happens is
Hello?
there is another study also, ANISA study.
Hello?
So
Yes.
point is that is RSV infection and the morbidity is not an exclusive disease of the preterms only and low birth weight only, but it may affect the term and the normal birth weight babies also. And as just you have told that it has more or less replaced the streptopneumonia as one of the leading cause of under 5, I mean pneumonia. And especially if we see that under 1 mortality is more than 70% than the under 5 mortality. And one of the leading cause is RSV.
RSV.
So it can affect any
So it can affect
pneumonia.
all infants, but the risk is more for the preterms and those who have other
Yes,
high
yes.
risk conditions. And incidentally, there was one study called the Mahan study. I think Vijay, this was done in Maharashtra. And
Tata Uggar Chevoli,
surprisingly,
yeah.
so
Yeah, by Dr. Sir.
surprisingly in that there was some, conflicting data which showed that the peak of RSV is more in the second half of the first year rather than in early infancy. And even hospitalization rates in the second year was as high as in the first year. So I think we need to have a little more data about RSV epidemic in our own country before we can confidently recommend this vaccine for all. Okay.
No, but Dr. Kasi,
Now,
that Mahan
yes,
study is from Gadchirauli, done by Dr.
yes,
Satav. I do not know
yes.
whether can be extrapolated and applied
No,
across
you
the country,
cannot. You
but there
cannot.
is a
That's what I said.
and I refer to that meta-analysis which I happened to read about a month
Yes, yes,
ago,
yes, yes,
in
yes,
2025. It talks
yes.
about substantial burden, and there is seasonality which is not as predictable as it is in the Western world. That's again a problem in our country. Though we see RSV around the year, it parallels your influenza, and
Yes,
we also see a second peak, especially in the western part, around
right,
January, February. Yeah.
right.
So there are a
Yeah,
lot of,
totally, totally. Now, there is
yeah.
lot of data, but I think there may be
Mhm.
differences. The differences were seen with pneumococcal also. Similarly, it may be applied with RSV. We need to have a little more data before we can
And
uniformly give it to every single child. Okay.
one more important thing is, as Jaideep said, though the risk of infection and complicated disease is higher in preterm babies, if you look at the hospitalized kids, it is more of full-term babies who get hospitalized
The
with
sheer
RSV.
numbers are more. That's why. The
Is
Absolutely, the
numbers.
because of
absolute number.
sheer
Yeah,
numbers, right?
correct,
Okay,
So
correct.
now,
percentage
Arun,
wise, preterms, yeah, total number terms.
yeah. Okay, let's go ahead. What is the schedule, Dr. Arun? Briefly, can you tell us for the monoclonal antibody? Let's stick to Nisumab because that's the only one available in our country.
So good thing is that it's a monoclonal antibody, starts working immediately. You can give it any time after birth as soon as the child is stable. It is available in two doses, 50 and 100 milligrams. 50 is given to children less than 5 kg. 5 kg, if it is 5 kg and above, that's 100 milligram. And
Yes.
once the child is 8 months plus, then you have to give 200 milligrams. So that means it's only few children who will need it because, it's only immunocompromised children who are on oxygen or, chronic lung disease. They should be given. So 200 is rarely used. It's given as 100 milligram each side, not as a 200 milligram single dose together.
And question to all the panelists. We don't have well-defined RSV season, as Vijay just mentioned. So is it like influenza? Will we give it at certain times or will we give it to all children as soon as they're born? What is the opinion of the panelists?
If the baby is not at high risk, then we can wait till the RSV season. If a baby
Oh,
is high risk of then we may give immediately anytime, irrespective of other vaccines. But I feel that if it's not a high risk, then we can wait till the season.
any other opinions or
So
But
all
that's what
agree
I've
with
been
Jaideep,
this?
doing.
yeah, yeah,
So that's what I'm
while I agree,
doing.
but there is a problem because of unpredictable seasonality in our country. So if we wait, we might even miss the bus. The child may, develop infection. So though it is not as predictable as the Western world. We definitely see more of RSV in the monsoon months. So
Okay.
July, August onwards. So uh, in private sector practice, I mean, have started talking about it to the parents. Not many of them convert, but they spend lakhs of rupees in uh,
Oh,
NICU.
in
But when you when you talk about RSU, some of that. But preterm babies, yes, the conversion is little better than full term babies.
yes, yes, certainly. So Arun, what about your opinion? As soon as the baby is born or will wait in
No, no.
full-term normal
These days,
babies?
children who are coming at this age, I
Mm.
tell them to wait till June, July, we'll give it then.
Yeah.
Because in Delhi, we
Okay.
don't see RSV at this time. It's mainly rainy season and post-rainy season, we see that.
Right. I think you're right. That applies to almost the entire country. Okay, next question. Now, what has been the impact data after its rollout in countries? What is the impact? How much has it reduced RSV related LRTA, RSV related
So
hospitalization?
that's what, impact we can see in various forms. So some studies have done like RSV, LRTI, something. Some studies have seen hospitalization. In fact, one Harmony trial saw also ICU admissions of RSV. So there is different endpoints where how you want to see the impact. But generally, if you want to remember out of that meta-analysis which was done, which had 16 studies. So grossly, if you want to remember two, three figures, against hospitalization, it's approximately 80%. Against
Right.
ICU admissions, around 85%. And total RSV infections are reduced by 70%. So 2, 3 figures. It's very difficult to remember all the studies, whatever. So
Good
approximately
figures,
80%. Yeah.
good figures, encouraging figures. How does it compare with maternal RSV? Of course, this is not applicable in our country because we don't have maternal vaccination, but
We
how
might
does it
soon get
compare?
it. Yeah.
Which is better? Which is better?
So I would definitely say the monoclonal antibodies are better. You're sure shot.
Yes,
Metal antibodies, we do
right.
not know how much of antibody would be transferred. You need to time the vaccination. Say a mother is expecting uh, months before the RSV season.
Yes.
By the time the protection is given to the to be born baby, it may not work. Monoclonal antibody is definitely better.
Yeah, I
No
think in
doubt
fact
about
there's
it.
been a publication from France where they've directly compared the efficacy against various endpoints, maternal immunization versus monoclonal antibodies, and monoclonal antibodies are definitely significantly superior to maternal. Now, are there any situations where you need to give both to an infant? I mean, you will give monoclonal antibodies to an infant who has already been a subject of maternal immunization. Are there any such conditions? Dr. Jaideep, can you elaborate?
It might happen when the mother has received the vaccine, then there is a preterm delivery. That is
Yes,
before
Exactly.
14 days of vaccination, when the
yes,
mother will not mount the antibody response. So if it's
right.
within, say, 14 days of receiving the vaccine, a preterm birth has happened, then definitely the baby needs monoclonal antibody, irrespective of what mother has received.
Okay, fine. The other situations is immunocompromised child, high risk child, and
Yeah.
of course where you do not know the immunization status of the mother. That happens in USA also, I think. But these are the three indications where you may need to give both. So now panel for all infants or only high risk preterms.
Offer to all, I think so.
Vijay.
Definitely for preterm, but offer to all. Let's not be judgmental. Let the decision be taken by the parents. It has definite
Okay.
merits. Yeah.
Yeah.
They are paying
Jaideep,
for it. So
agree?
Yes, yes. Yeah,
Okay,
agreed,
fine.
agreed.
So recommendation for all, but special emphasis on the high risk, including all preterms. Now, I think we'll go a little fast because almost taken 1 hour for 3 vaccines. But we come to another one, which is a real talking point, has always been a talking point ever since the vaccine was licensed. Now, first, we have to choose between 1 and 2. Now, Dr. Jaideep, we are talking about 2 doses, a lot of talk about 2 doses, but uniformly the ACVIP has recommended 1 dose. Was there any time in the past where ACVIP had recommended 2 doses of typhoid vaccine?
Yeah, it was in the very initial phase. Actually, the typhoid conjugate vaccine was launched around 2013.
Yeah.
So initially there was a recommendation of 2 doses. Then there were some studies which mainly with this TT conjugate vaccine. There were studies in 2 cohorts, as you know. I mean,
Yeah.
so that showed the efficacy of a single dose and the persistence of antibody beyond 5 years. And then there was the Malawi study with a 7-year follow-up, which prompted ACVIP to make it a single dose schedule.
Yeah. So when the vaccine was first licensed in 2013, we did not have the 7-year follow-up data for the TCV.
Yes.
What we had was only the 18 months. And at 18 months, the seroconversion rates, especially in children below 2 years, had dropped down to 62%. And there was a significant drop in antibody type. Based on that, it was during Vipin Vasishtha's time that a 2-dose schedule. Then came the 7 years data and the SAGE recommendation. In 2018, the ACVIP changed it over to 1 dose, although it has not been a very popular decision amongst many of the pediatricians in our country and the key opinion leaders as well. So now, why are we again talking about 2 doses? Any new data which has come in, Vijay?
So the initial indication, this vaccine was put to use in our neighboring countries and African countries. So the earlier indication came from Malawi data, where they published
Yes,
their 4 years data, and the
yes,
efficacy dropped to about 78%, if
yes,
I'm right, if I recollect the
yes,
figures right. Then an important publication came from Bangladesh. Bangladesh, what they did, that uh, studied this vaccine initially, and the comparator, the placebo arm, was offered Japanese encephalitis vaccine. At then, after 3 years, they offered this vaccine, looking at the good efficacy that it displayed. The other cohort was also given this conjugate vaccine. So now they have two cohorts: one which the old vaccinated subjects
Yes.
and recently vaccinated subjects. And what they
Yes.
realized that the incidence of typhoid, they looked at the case control study, and the incidence of typhoid was 3 times higher in the cohorts which was vaccinated in the first shot, the old cohort. And the efficacy, when they looked at efficacy closely, it oral efficacy dipped to 50% plus, and especially in subjects who were vaccinated below the age of 2 years, the efficacy dropped to 24-25%. So
Yeah.
this is where they looked at again carefully, and so there is a substance, and we have always been saying that it is a bacterial disease. Even natural infection does not offer long-term protection, and inoculum-based disease where a second dose would be required. So I personally have always felt that a second dose is required, and now we have evidence from this Malawi, and we have also shown in the immunogenicity study that there is an excellent boostability. The titers go up when you boost it, and the avidity, the percentage seroconversion and antibody titers were much higher in boosted individuals as compared to non-boosted. And we rested our recommendation of single dose based on the arbitrary, antibody serology. In the absence of definite correlate of protection, we based our recommendation on the presumed correlate of protection.
Now, I think
So
basically, see, this vaccine is based on the Vietnamese vaccine. And if you look at the Vietnamese vaccine, it began with a 2-dose schedule, and then they dropped the 2 dose to 1 dose because they did not find any difference. So there was some, definite data to suggest that 1 dose may be sufficient. Malawi study gave the first indication. 78%, 72% in those less than 2 years, but those figures was not statistically significant. But the Bangladesh study has given us definite data. See, below 7 years, in those who had taken the vaccine 5 years and below, the efficacy had come down to 24%. And remember, the epidemiology of typhoid is quite similar in Bangladesh and India. We have almost the same burden of typhoid. So probably we can extrapolate their findings to our country, and probably even looking at that, even the SAGE recently has recommended a second dose,
yeah,
specifically where you give the first dose below the age of 1 year. So now
true.
again, question to all: second dose, booster necessary or not necessary?
Necessary,
Arun,
and at
Yeah,
school
yeah.
entry.
okay,
Yeah.
fine. So a booster dose may probably be recommended. And if you give it, especially if the child has received the first dose before 1 year, you should give it at school entry, because whatever waning has been observed at least 3 to 5 years
3 to
after
5
giving the
years.
priming doses. Okay. Again, this is the recommendation of this panel, not the IAP recommendation. I want to make it very, very clear to the
Yeah.
audience. Right. Do you think there's a time when we may need more than one booster? Open to question. Okay.
Oh,
Now
keep our minds open.
we'll go a little fast now. Now,
Yeah.
rabies, we began with 5-dose PEP, 3-dose pre-exposure. Then we came down to 4-dose and 2-dose. Again, recent the purple book states 5-dose and 3-dose. Jaideep, why did 5 become 4, and why did 4 become 5 again? Briefly, can you give
Yeah,
us an answer?
briefly, actually, WHO recommended a 4-dose post-exposure and 2-dose pre-exposure. So
Yes.
probably ACV went with that.
Yes.
Now, the point is that there is very limited evidence that a 4-dose schedule has comparable efficacy to a 5-dose. And definitely, rabies is a universally fatal disease.
Yes.
So, besides our national program also endorses, and all the recommendations by AppCry and others recommends a 5-dose post-exposure. So that's why maybe ACVIP has gone back to 5. I think because it's a universally fatal disease, better to go for a 5-dose, though we know that the initial 3 doses are most important within 10 days, but definitely a
Yeah.
2-dose is better.
But
Any other
Dr.
comment?
Kasi,
Yeah.
yeah. So there is enough evidence to say that that fifth dose does not really, matter
Exactly.
much.
It is based on
How-
robust data.
Yeah, absolutely. And however, to be in sync with the national program and
Exactly.
in a disease which is so fatal, more is not harmful.
I think
So,
fine. I think you have hit the
so
nail on the head. It's more to be in sync with the government recommendations and I think this was something that all of us, I guess, we discussed in every panel discussion. However, ever times you discuss, that question is always raised. So I think to make things easy, the IAP has gone back now again to the original. So that's it. Now, Dr. Arun, a 6-year child received pre-exposure prophylaxis because they were going to adopt a dog. After 6 months, there is a re-exposure. He received again 0 and 3. Over the next 2 years, he received pre-exposure, re-exposure 3 times. The parents are fed up and come and ask you, doctor, is there any way out? How long will this go on? Any suggestions?
So,
Will you
it's
keep
become
on
very
offering 0 and 3 for every re-exposure?
become a very common problem, especially post-COVID.
Yes.
Everybody's got a pet now. One,
Yes.
2, 3 pets, and I have this issue every week almost.
Ah,
So, I go more by history. So if suppose mostly these people, small houses, flats, they have very small dogs who don't even leave their houses. So I just go by
yes.
the history. If it's class 3, I would tell them, okay, give it. If it's on the face, fingers, I said, give it. But suppose the history is that the dog has never been outside the house. And, the exposure, like WHO also says, in case of suspected rabid animal bite, so when you're not
Yeah.
suspecting rabid animal, the dog has never been out of the house. So I just tell them to clean the wound every time 10 minutes with Savlon or a harsh soap and apply Betadine 3-4 times a day, 10 days. But it's a deep bite close to the face or fingers, then I tell them, okay, I'll give 2 more doses. But most of the time, I just take a tail history and tell them just do the cleaning.
Any role for doing
And it's
yearly
not
antibody
possible.
titers? No, any
It's not
role for
possible.
doing?
I tried to find out even the best of labs, Dr. Lal Lab, the other
No, no,
more
no.
famous labs
This is
also.
done
They don't
only
do
in
that
reference
title.
lab. Only
They don't do the
the
lab. They
labs,
don't
the
do.
labs
No,
they
no.
do by ELISA, they don't do the RFFIT.
Yeah,
ELISA is not
so
very reliable. So
so
I
they
think
don't do. It's not
they
easy
don't
to
do it.
do that.
So that is not possible. So I think
Yeah.
Arun has brought out the point very well. Now, see, basically in an endemic country like India, every dog is suspected rabid. But in a situation where the dog is vaccinated adequately and never comes into contact with a stray dog, like the owner himself takes the baby, the dog out for a walk and sees to it never comes into contact with any other stray animals, and I think that's the place where you can relax and say, okay, wound hygiene and nothing more than that is necessary. I think this is somewhere which you have to tackle it on a case to case basis. You can't
Yes,
have
case to case.
hard and
Yes.
rigid rules. Otherwise, this kid will lang up with 0 and 3 every 3 to 4 months. Right? Okay. Now, again, there's a lot of discussion. We have live attenuated and the inactivated. I mean, I don't know. There's a lot of discussion about in this recent times. How do you compare the two? What are the facts? Any advantages, disadvantages of one over the other? Yeah, who will take this? Dr. Vijay?
so So it is, I mean, I would say that we have a very long-standing data with the inactivated vaccine.
Yes,
One. Secondly, in an outbreak kind of a situation where you can't just screen out immunocompromised or those who cannot be given live vaccine, it is
right.
inactivated vaccine which would be preferred. However, in terms of protection offered, they both are on par. For
What?
Chinese vaccine, we have a mindset that, I mean, this may be inferior, but it has been extensively used in the country where it has been produced and excellent data. We
What
have
about post exposure prophylaxis, Dr. Vijay? Any preference for
post
any particular brand? Post exposure.
I don't know. I don't really think.
Because see, because there is data which shows that as far as inactivated vaccine, more than 90% achieve seroconversion within 18 days, whereas for the inactivated, it takes about 3 to 4 weeks. So probably in a post-exposure situation, the inactivated vaccine would be better. And of course, immunocompromised, you cannot use a live vaccine. I think as far as outbreak is concerned, I think there is data from China to show that it's quite effective during outbreaks also. So these are the
Yeah.
major differences. Now, we have three different antigens for the inactivated vaccine: the HM175, There are two vaccines, that is Havrix and now the Havipure. We have GBM, which is Avaxim, and TZ24, which is our Chinese vaccine. Any difference in them, or we'll take them all as equivalent?
For all practical purposes, it is equivalent, I would say. GBM is
Right.
no longer available,
Yeah.
and Chinese is mindset.
Okay. Now, next, Jaydeep. Very often asked question. There is no JE in my area. Adjoining district is JE endemic. Should I routinely administer JE vaccines in my practice? Dr. Jaydeep.
Actually, with so much movement of people nowadays, I mean, you are not restricted to a place. There is traveling, there is movement, and when more than half of India is endemic for JE, it's always better to take JE vaccine, though it may not be in that area or the district concerned, but even if it's in adjoining district, and when there is always chance of movement, because again, it's only vaccine preventable viral encephalitis that we can prevent. So maybe it's prudent to administer it routinely.
Okay, now taking your recommendation, I have administered the JE vaccine, the BE vaccine, at 12 and 13 months to my patient. I'm not in a JE endemic area. Now my child is now shifting to a JE endemic area at 8 years of age, that is 7 years after the vaccine. Are the vaccines administered earlier sufficient to assure protection, or should I give him a booster dose? What are your thoughts? Vijay?
The vaccine is licensed for single dose also, but if you look at the trials, there is definite waning of both seroconversion and antibody titers. So 2 doses given 1 month apart mount good response. As on today, there is no recommendation of a booster dose. But I believe looking at the kinetics of antibody, maybe for such a child, given the seriousness of the disease that we have, maybe I may offer a booster dose to such a child who moves to an endemic area.
There was a study done in Thailand which compared 1 and 2 doses of this Ixiaro brand, the pediatric brand. And what they found was that between the booster and the non-boosted group, the seroconversion rate at the end of 5 years remained at 100% for the boosted, whereas for the non-boosted it had come down to 92%, and there was significant difference in antibodies. So there is definite waning. And if you see in a non-endemic country like USA, the CDC says at the end of 1 year you give a booster because almost about 35% become susceptible at the end of 1 year. Now, this particular child, you are in a non-endemic area, not in a declared non-endemic area, but you do not know. There may be natural exposure or there may be no natural exposure. If there is no natural exposure, there is no natural boosting, and he may become seronegative. And JE is a short incubation illness. You require protective antibody. You can't depend upon the anamnestic response. So you definitely. So I think to all those who give routinely non-endemic area, this is something I think one needs to keep in mind when you offer the vaccine. This is just one
But there is
concept
no
I wanted to.
recommendation as such. As on
There
today,
is
there is
no,
no
I
recommendation.
know.
But yeah.
There is no
But
recommendation.
as I said, I would offer such a child this thing.
Yeah, exactly.
And if you look at the schedule that we practice, 2 doses 1 month apart. But if you look at the interchangeability study,
Yes,
the second dose was given a year later.
Yeah, that is true.
So
That
I
is
mean,
true.
so
In
having
fact,
practiced 2 doses close to in less than a month's duration, I would definitely err on safer side, give a booster at 5 years.
Right.
I mean, if
Now,
such a child moves there.
Agree.
Dr. Arun, what has prompted the change from quadrivalent to trivalent influenza vaccine? And are there any risk of re-emergence of the B Yamagata strain at some time in the near future? What are your thoughts about this?
So what prompted was that, since all these surveillance is being done by WHO at various centers, including 13 in India, they have found that after March 2020, since the COVID came, Yamagata is out of circulation. So although we can say it's extinct, but it's not declared as extinct. And as the virus is in a single-stranded RNA virus, which keeps changing every year and keeps changing very often, more than a year, there is always a small risk of reemergence, just like H1N1 also reemerged, but there's always a risk. So that means we have to be on the guard. The surveillance has to be kept. And as soon as it reemerges, we might go back to quadrivalent again.
So as of now, we should definitely
Should the
use only the
tribal.
tribal.
Yes.
Okay. Any other comments from the other panelists? All
No.
agree with this? Okay, fine. Now, let's come to another exciting vaccine which will be introduced very soon. PCV20, as you all know, is now licensed above 18 years, but it has gone for approval even in the beyond 6 weeks of age. Probably it may come very soon. Now, Dr. Arun, in the Indian context, what are the expected additional benefits of PCV20 over PCV13 and 14?
So if we
According to
see
available data.
yeah. So if we see percentage-wise, another increment of 4 to 5%, because it
Right.
has 7 other serotypes, including
Yes.
the 22F, 23, the 33F for PCV14, and also the 8, 11F, 12F, 15B, 23F. So there'll be 7 more serotypes as compared to PCV13 and almost 6 more as compared to PCV14. So the
Yes.
increment would be to the tune of around 5% more.
Okay. Actually, in the USA, the
For adults, it's different. For children, it's different.
no. In USA, in children below 5 years, the 7 additional serotypes accounted for almost 32% of all IPDs. So there is going to be a real benefit. But that is, they have such an excellent surveillance system. We don't have any surveillance system to give us that confident figures that this will be the extra protection
No,
offered by
but 13, 14
PCV20.
already offer around 70% to 74%. So if we add 30
Yeah.
more, then it will be on 100.
No,
No,
but
no, no.
actually, if you look at the absolute numbers, 32% appears very huge. But
Yes.
look at
Yes.
the number of pneumococcal
It's
diseases that
only
is
5 to
left
7%
behind in the
more.
US.
Yes.
Hardly.
So overall, I think 5% to 7%, as you said, that is going to be the expected benefit. I mean, we must remember that we have to consider how much extra benefit does it give. I mean, for that doubtful 5 to 7%, are you going to pay another 2,000 or 3,000 extra? That is something we really need to think about. I think we should have another panel discussion on that. We won't discuss that today. Now, PCV 13 versus 14. Very briefly, Dr. Jaideep.
Yeah, briefly, actually, see the non-inferiority of PCV14 of the 12 common serotypes was proven. And
Yes.
then the 22F and 33F also were non-inferior to the serotype 3. Bigger. But the crux again becomes the 6A, which we cannot
Yes.
ignore. And
Yes.
PCV13 still has the advantage of about 3% better coverage than PCV14 as of now. So it's close, but again, PCV13 scores over a bit due to the 6A.
Okay,
I think
Doctor.
6A would definitely be protected by 6B, but what will go unprotected is 6C.
6C
By the
will go
6B antibodies. By the 6B antibodies. 6A is not of a great
B doesn't
concern
protect
with
against C,
PCV14.
but partial against A.
6C.
Yeah.
Yeah.
I think there are a lot of review studies in the Western countries, specifically in the European countries. 6B has given very good cross protection against 6A.
Yeah.
But there are 2 studies, one from Japan and one from South Korea, where the cross protection is very not so good. So it is possible that there may be a geographical variation. So we cannot assume that 6B is going to give 100% cross protection against 6A. There's a definite need for 6A as well. Okay, now we have PCV13 with CRM, we have PCV13 with TT. Any differences, any preferences, Dr. Vijay?
A short answer, from safety efficacy point of view, there is no difference.
Okay.
Choose one which is available. Cost plays a role. Theoretically, there is something called carrier-based epitope suppression and inferior, but that does not translate into inferior efficacy of one over the other. And now the TT conjugate vaccine has recommendation for booster also.
Yes. Okay, so now on paper, at least both are the same. Although if you see their licensure study, the OPA titers are far lower with PCV-TT compared to CRM1, and that is the functional antibody titers. We will never know that it works equally well. See, we must remember, Vijay, 0.35 is for IPD, not for pneumonia. For pneumonia, we require higher antibody titers.
Agreed.
So any vaccine which gives higher antibody titers will be better for pneumonia. I think we need to keep that in mind, right?
Definitely.
I think, which are the PCVs licensed for booster dose in our country, Dr. Arun? Quick.
So 13, 10 were originally licensed, the new 10 after Gambia study. Then also now the TT has also been licensed and PC14 is awaiting another 2-3 months should come.
Okay, fine. Now we come to a couple of the last few questions. Why is IAP still recommending a bird dose of OPV when the aim of IAP is to stop OPV at all? Dr. Vijay.
So in India, we follow 6, 10, 14 schedule for IPV.
Yes, yes.
OPV helps to prime the immune system. It also sort of tickles the gut and induces it is supposed to have a better mucosal immunity. And OPV administered at birth, the risk of VAP is almost negligible. So it is still worth priming the immune system.
It may or may not benefit, but definitely it will not harm.
It will not harm, definitely.
Okay, fine. Now, if you remember in 2016 when we changed over to bivalent polio, we started introduction of one IM IPV as a risk mitigation strategy, so that we population immune against type 2 and some boosting against immune response to type 1 and type 3. Then we found that 2 doses of fractional doses are better than 1 dose of IM. So we had a 6 and 14 week schedule. Now we have a 6 weeks, 14 weeks and 9 month schedule in the NIP. So do you still consider this as a risk mitigation strategy, or is the schedule alone sufficient for protection against paralytic polio without OPV? Dr. JC, what is your, Jaideep, what is your opinion about this particular aspect?
See, initially the 6 and 14 week schedule, which was started, it showed that the type 2 seroconversion was 80%, then the 9-month was added. But along with OPV, definitely it serves some purpose of narrowing the immunity gap and that VAP elimination. But still the 6, 14 and 9-month schedule of fractional is a risk mitigation strategy only.
Right.
Yes.
Now, how does this fractional dose compare with what we are using in IAP, 3+1+1 schedule, from the point of view of seroconversion and from the point of view antibody titers both? How do you compare the two schedules?
See, that's why the booster is required, that 18-month booster that's the ACVIP recommends.
Right.
It's because there is definitely waning, and the 5-year booster has been added later because we need protection up to 5 years. And as we know, some countries, they boost at 10 years also with IPV.
Yes.
But yet, right now, it's up to 5 years. So it's definitely better.
Dr. Vijay, you read any article about IP or OPV, most of the article talks only about seroconversion. They rarely mention antibody titers. Why is this so? Is seroconversion sufficient for protection against paralytic polio? If that is the case, is there any additional benefit of higher antibody titers with the IM schedule? What is crucial in protection against polio?
So as far as protection against paralytic polio, a meaningful seroconversion where 1:8 titer is achieved is enough.
Yes.
However, antibody titers are important to halt the transmission from one person to the other. So it would break the chain of transmission. So higher antibodies would be required. We probably are required. We do not know as on today whether antibody really matter or not, but immunologically and scientifically, higher antibody titers would definitely break the chain of transmission.
Even
But for protection,
would
individual protection against paralytic polio, seroconversion is adequate, more than enough.
Lot of confusing data about the validity of the statement that antibody are more protective. The very fact does IPV give any intestinal protection at all is questionable in one who is not primed with OPV.
But look at the Western world where there is no prime with OPV, but high antibody titers in the serum, like your HPV.
But still they have had
protect against mucosal disease.
They have had occasions where OPV has been detected in the environmental samples, indicating that it may not halt transmission. It will prevent the vaccine from getting paralytic polio. Moreover, there has been a meta-analysis and looked at how long does this mucosal immunity last. It's just a few months, not longer than that. I think there has to be a rethink about this. We should probably stop chasing antibody titers and look at more at seroconversions.
But
You know,
at the same, all the more reason that we need to have very high antibody titers to, prevent that whatever little benefit it has.
there
It's
have
only
been
high antibody levels which will cross over, which will protect at mucosal level. I
theoretically
agree
your
with you. I
statement is
mean,
very valid, but
yeah, I agree
theoretically
with
very
you.
valid, but no proof, no clinical proof
That's
of
the
this
knowledge
statement.
gap. That's the knowledge.
Okay,
I agree
so
with you. I agree.
audience to remember that seroconversion is crucial. High antibody titers may not be of much benefit, additional benefit. Okay, now we come to another common situation. Infant has received the first dose of pentavalent OPV, Rota, PCV fractional dose at 6 weeks. Something has gone wrong. They now come back to you. I want to take further doses with you. Now, will you consider the first dose of fractional dose IPV administered at 6 weeks as the first of a 3-dose schedule and administer 2 more doses? Basically the question is, are intradermal and intramuscular schedules interchangeable? Anyone can take this question.
So they may not be interchangeable, but a baby who has received first of FIPV, I would give him to complete the primary by 2 additional intramuscular and also give him the second year booster and the 5th year booster.
Even I would do that.
That
Consider
should
it as
suffice.
first
Okay,
dose.
fine. So
Yeah.
you
We
continue
cannot
the
give
schedule.
ID.
You cannot give ID, but you will not discount this dose. You will take it as the
Yes.
first
Will
dose.
not. Definitely. Yes,
Fine.
yes.
I think I have finished all my prepared questions. I think I'll stop sharing. We can now take some questions which are there in chat box. Who will take it? Dr. Sumita or Ravi Shankar? Anyone?
Shruti is there, sir.
Yes.
Shruti?
Shruti, yes, please.
Yes, sir. So, we have the first question from Ravi Shankar, sir, with respect to the HPV vaccine, sir. He wants to know about the oropharyngeal level. Is it the same as that of the cervical level?
Yeah, who will take this?
Oropharyngeal, difficult to say.
No.
Yeah,
Now, I
know.
think now there is no definite differences in the etiopathogenesis of cancers at different sites. It is all the same. There should be a mucosal aberration. The HPV should stick there and then enter the basement membrane, break in the basement, lower canal set to the upper canal. That is a common all over. So I think there should not be any differences in the quantity of antibodies that are necessary for preventing infection. In fact, there has been a study where they have taken oral washings and looked at the anti-HPV and 16 and 18 titers, and they have found very high titers in those who have been vaccinated. So I think HPV will work equally well even at other sites in those who have been vaccinated. 3 doses, 2 doses, 1 dose, I think it's all going to be the same only. Now, someone has asked efficacy of HPV in women 60 plus. Why do 60 plus women need an HPV vaccine? Huh? Any quick comments?
No.
Okay.
It may not harm.
Ravi has already answered. Can Gardasil be used beyond 15 years of age in India? Anyone can answer, please.
Off-label with consent of the parent, since it is licensed for use in that age group in the Western world.
I think in
we
women
can
it is
use it.
licensed till 26 years. In females. Right. Okay. So should we do serology to know? Should we do the serology to know whether it is seropositive or negative?
No.
Already answered. No.
No. Dr. Shruti, I hope
That
you
is
don't
with
mind.
respect
I'm
to
reading
dengue
the
vaccine, I
questions.
believe.
Yes,
Okay.
sir. Yes.
Okay.
I believe that is with respect to dengue vaccine, that question.
Dengue vaccine.
Yes.
Exactly.
Okay.
Yes. Okay. So I think there's absolutely no
questions have
need,
been
no
answered.
recommend. Yes. Now, in dengue infection, it's the antigen, antibody, and complement complex that cause damage to the vascular endothelium, causing increase, etc. So, if dengue vaccine is given and used, so is there a risk of complications?
No.
So that is what we clarified. Na? If you have a
Yes.
good tetravalent response, the risk of antibody-dependent enhancement does not occur because the
Yes.
antibodies protect. That did not happen with the dengue vaccine. And in
Yes.
seronegative, the vaccine acted as the first infection, and the subsequent infection led to a ADE. and deaths also in a few vaccines.
So in both the TAC-003, that is Qdenga, and the Buchanan vaccine, which Dr. Vijay spoke about, there has been no demonstration of ADE in the clinical trials. Okay, so it's assumed that ADE will not occur and these vaccines are safe. Okay, I think Ravi Shankar has been answering most of the question. How many doses of
Doses of
RSV?
RSV.
RSV, I think this is monoclonal antibodies, if they can afford. I think it's only one dose for
Yes.
normal
Yeah,
health
single dose, single dose, single
and
dose.
2 doses for those who are at high
Only
risk.
high risk in the second year.
Okay, if second dose has to be given, what is the interval between the two typhoid vaccines? I think we already discussed that around 3 to 5 years after the
5
primary
years.
dose, if the first dose has been given below the age of 5 years. And if the first dose has been given beyond 5 years, there's no need for booster at all.
Single dose.
As on
Sir,
today.
regarding TCV, please ask others, sir. We have seen patients with 2 doses in the first year who are culture positive. I think Dr. Vijay very clearly said this is an inoculum-based disease. So even 2 doses, 3 doses may not work. So
And
it's
we
an
never
so
claimed it to be 100% efficacious.
yes. And once 2 doses don't work, I think you have to concentrate on wash rather than giving more doses of the vaccine.
Yeah, yeah, yeah.
ARV 2 doses should be given in India.
Pre-exposure, I think he meant.
No, this
Yeah,
is for the child who gets bit every month. The question which I
Okay,
had.
okay.
So he's
Re-exposure
written that
zero
every time you
kg.
should give it.
Yes, yes.
Dr. Ravi Shankar has asked one very interesting question. Men are moving, but not the mosquitoes. Should we still give JE vaccine in non-endemic areas?
My
I
view is JE is something which is very bad disease. 30% die, 30% survive with sequelae. Let's be liberal. It's a safe vaccine.
okay.
When
Now,
in doubt, offer it.
Not
now
costly too.
let's talk about the mosquito movements. There was an outbreak in Pune. And when they looked at the lineage of those mosquitoes, they were from an outbreak which occurred in Sholapur. And I think Sholapur and Pune are at least about 400, 300 kilometers apart, Vijay? 300 to
200.
400, 200
Yeah,
kilometers. So that
200
mosquitoes have
plus.
traveled. There was a study done in this Sahelian desert in South Africa where they tagged the mosquitoes and looked at their movements. You know, mosquitoes traveled about 300 kilometers in one night over the waves of the wind that travel over the desert. So mosquitoes are more mobile than human beings. So I think mosquitoes definitely travel and spread the disease. How is dengue spreading all over the countries? Because the mosquitoes are there in all that tire tubes with water in it and so many places. So mosquitoes are very avid travelers. Let's not underestimate them.
They travel
Sir,
on
what
Bangkok Mumbai flight.
yes. Sir, what about Delhi? Should we be giving JE vaccine regularly? Huh?
We don't
Arun.
give. I
Depends
don't
on
give. No,
depends
I
on
don't give. I don't give.
Okay. Now, trivalent vaccines in shortage. Yes, it will be coming very soon. Is booster at 15 months required for PCV14? I think the answer is any PCV you require a booster because
booster is
antibodies
required.
wane even with 3 doses. And remember, there are certain serotypes which peak in the second year, especially serotype 1, which is a very important serotype. So booster is definitely necessary.
I think what
So
the question he means is that PCV14 is
PCV14.
not recommended for booster
Exactly. So
dosing.
you
Yeah, it
give
can be
some
used.
other, give PCV13, give something else, but a booster is necessary. No, PCV20 is still not recommended. I think we already went with it.
Hello.
So
He
only
answered
bird
all
dose
the
of
questions.
OP, no further oral doses. I think it's right. So as far as IAP is concerned, no further doses except the bird dose and during the supplementary immunization activities.
Correct. Yeah.
But
Okay.
don't discourage anyone who is on
Asking for
the
first dose.
NIP days,
Yeah.
the sub-national immunization day. Please
Sir, should
don't discuss.
meningococcal vaccine be advised routinely or in high risk patients only? Why the silence? Hey, panelists,
No,
come on.
I mean, meningococcal vaccine is an excellent vaccine. Meningococcal
Hmm.
disease is devastating disease, and where it is prevalent, it should be offered. Where it is not prevalent, if patients ask, like there are patients in Mumbai who ask me, pneumococcal is there any other vaccine to prevent meningitis? I tell them this is the vaccine available. We don't see much of disease, but it's an excellent and safe vaccine. So let the parents decide. One need not,
Okay.
I mean,
I
that is
Yeah,
what I
I
do.
think let's not be very rigid about this.
Yeah.
Huh? Now, first dose government sector 6 weeks given FIDB, second dose Pentav given without IP or OP in prior, third dose can be given. I think if patient can't afford, don't fool about by not giving IPV. Send him back to the government sector and give it, or tell him this is going to hexavalent is going to cost so much. Take it. You can even prefer to give the wholesale since it is much less expensive compared to the SLR. But IPV cannot be missed because we are giving only BOPV, and there is no type 2. There is no immunity against type 2 in those children who do not receive IPV. I think they should be referred back. Why is OPV given at birth? I think Vijay has answered because it primes the immune system for both subsequent OPV and IPV both. Booster dose of typhoid vaccine given at 5 years, duration of immunity, no studies so far. Maybe in 5 years later, we will get that data. I think now regarding JE, there's just one point I want to tell you, See, there's a very interesting study which looked at JE in Tanjavur district. See, Tanjavur district is non-endemic. Adjacent Nellore district, rice growing district, is endemic. There are no local cases of JE, only imported cases in Tanjavur. They did the antibody titers in the population 20 years apart. And what was 3 to 5% seroprevalence has risen to almost 60-65% over 10 to 15 years, indicating that absence of a JE case does not mean that there is no infection in a close by
Circulation.
area. It is possible circulation is there, but disease is not being caused. So I think we should be a little more relaxed in recommending JE vaccine, especially if you are, very adjacent to a JE endemic area and you have environmental conditions which are conducive for the spread of JE. So I think with that we
You
finish
should do
today's
such
discussion.
study. Such a study should be done in Bangalore also. Kolar
Exactly.
Yeah, same thing. In
produces
Bangalore, we
the
don't have
Genvac,
active cases.
We don't
but
have
you
it.
don't have JE.
Where we are surrounded by JE cases around Bangalore, like
Yes.
Kolar, Mandya,
Yeah.
everything
Yes.
like that. Yeah.
In fact, they found that the ratio of the cattle and the pigs is what decides whether infection will occur or no. If you have more pigs compared to cattle, JE transmission disease occurs. But if you have more cattle compared to the pigs, for some reason the mosquitoes like to go and bite the cattle but not the humans. So disease in humans, and this has been proven in Tanjavur district. So I think a lot of ifs and buts. So I think thanks to the organizers for giving us this opportunity. I mean, I do not know about the others, but I thoroughly enjoyed this particular panel discussion, and thanks to this great panelists. Thank you once again. Thank you.
Let me make a comment that Dr. Kasi said in the beginning that he's having an expert panel. I would say, I mean, this was one of the most important and learning experience for me. And when Dr. Kasi is there as moderator steering the show, it's enjoyable and a lot of learning.
Fully agree.
Thank you.
Encyclopedia of vaccinology.
Thank
It's
you.
been an amazing evening, sir. Thank you so much.
Thank you. Thank you.
Thank you.
Thank you very much. Thank you very much.
So
sir.
before Kushal tells his Vande Mataram, let me thank Dr. Ramakant Patil, EB of Maharashtra, Vijay Bade from Pune, Dr. Ganesh Kulkarni from Aurangabad, Kailash Vaidya from Pune, Dr. Gopabandhu from Orissa, Nandini Kumaran and Jalil from Coimbatore, Jnanmurthy Bas, Nagesh, Pramod, Palnetra, Panchaksharaya, and Nandakumar, President of IAP Kerala, for being there and listening to things. Thank you all. And also Anusha Raj and Raghunath from Bangalore and Mysore are there. Thank you a lot.
Thank you.
Thank you very
over
much.
to you.
Thank you.
Thank
Kushal,
you.
over to you. Yeah.
Thank you, sir.
you.
Thank you very much. It was a wonderful discussion on vaccinology moderated by our Kasi sir, and the panelists were too good, and they have cleared most of the doubts and also the questions on the chat box. I thank everyone, and we would like to meet in another 15 days with another episode of Samanvay. Thank you one and all. Thank you very much.
Thank you,
you.
sir.
Good night.
Thank you. Thank you. Good night.
Thank you. Good night. Thank you,
Bye-bye.
sir.
Bye.
Thank
Bye.